Hello, my name is Andrea Aguilar. I am a PGY1 pharmacy practice resident at the Central Iowa VA in Des Moines, Iowa. Welcome to my lightning presentation on the use of erythropoiesis stimulating agents to treat anemia in patients with chronic kidney disease. The contents of this presentation were developed to improve patient care and represent my views only, which are based on the references at the end of this presentation. They do not represent the views of the Department of Veterans Affairs or the United States government.
After viewing this presentation, you should be able to recall the mechanism of action of ESA agents, know when ESA therapy is indicated in anemia of chronic kidney disease, understand the risks associated with ESA therapy, and be familiar with dosing and monitoring of ESA agents. Anemia in CKD is associated with reduced quality of life and increased cardiovascular disease, hospitalizations, cognitive impairment, and mortality. As kidney disease progresses, anemia increases in prevalence and often the cause is multifactorial. Some examples of independent causes of anemia in CKD patients are listed in the bubble graphic to the left, with many patients having more than one of these contributing to their low hemoglobin level. When a patient presents with anemia, all causes must be assessed for appropriate treatment. Since our focus is erythropoiesis stimulating agents, I will do a quick review on the pathophysiology and mechanism of action of ESA agents. We know that red blood cells are produced in the bone marrow by a process called erythropoiesis. But for this process to take place, the hormone erythropoietin, or EPO, must be secreted by the kidneys. With impaired renal function, the kidneys are not able to produce adequate erythropoietin. ESAs are exogenous erythropoietin, which replete the deficiency observed in anemia of CKD. EPO deficiency usually presents as normocytic normochromic anemia. When is ESA therapy indicated? Typically, iron supplementation is trialed first prior to initiation of ESA therapy if the transfer and saturation is at or below 20% and ferritin is at or below 500 nanograms per milliliter. For both hemodialysis and non-hemodialysis patients, if hemoglobin remains below 10 despite a TSAT greater than 20% and a ferritin level above 200 nanograms per milliliter, then ESA therapy should be considered. The overall goal with ESA therapy is to avoid the need for red cell transfusions due to risks associated with it. For non-hemodialysis patients, if hemoglobin levels surpass 10, ESA dose should be reduced or held until hemoglobin drops below 10. This is slightly different for hemodialysis patients. In this population, if hemoglobin is nearing or above 11, a dose reduction or holding of ESA therapy is recommended. In both cases, ESA therapy should be restarted at the lowest effective dose. Some key points regarding the risks of ESA therapy include thrombosis, MI, stroke, TIA, and seizures. Another significant risk is the possible tumor progression in patients with cancer. The most common adverse effect is increased blood pressure, which is why ESA therapy is contraindicated in uncontrolled hypertension. Among both dialysis and non-dialysis CKD patients, multiple studies have shown that targeting hemoglobin levels at or above 13 grams per deciliter is associated with increased risk of adverse outcomes. It is because of these significant risks associated with ESA that the use must be carefully evaluated to look at the risk versus benefits of it. Some additional considerations that may help you determine the best course of action is to assess the rate of hemoglobin concentration, which may indicate the likelihood of needing a transfusion, prior response to iron therapy, the risk of needing a transfusion, as well as the risks of ESA therapy. I'll briefly review the two ESA agents. Epoetin is a recombinant human EPO, and darbepoetin is a synthetic EPO analog. Some studies have shown that the subcutaneous administration of epoetin may result in lower doses needed to achieve a target hemoglobin level compared to intravenous administration of epoetin. This may be helpful in a patient who is at higher risk for experiencing any of the adverse effects discussed in the previous slide. Darbepoetin differs from epoetin in that it is a glycosylated protein and exhibits a longer half-life, allowing for a longer dosing interval. Clinical practice guidelines consider epoetin and darbepoetin to be therapeutic equivalents. I have listed the recommended dosing per UpToDate for each of the agents. In terms of monitoring, iron status should be evaluated prior to and during ESA treatment. This is because effective erythropoiesis is dependent on adequate availability of both erythropoietin and iron. Hemoglobin should be monitored weekly after the initiation and following dose adjustments until a stable hemoglobin level has been reached. Once a patient is on a stable regimen, hemoglobin monitoring can be extended to every 4 weeks. Watch out for any hemoglobin increase of over 1 gram per deciliter in any 2-week period because this will likely require a dose reduction or temporary hold of ESA therapy. Monitor blood pressure and signs or symptoms of seizures throughout ESA treatment. Do not increase the dose more frequently than once every 4 weeks to avoid hemoglobin increasing too quickly. Decreases in dose, however, can occur more frequently. I would also caution that in some patients, hemoglobin may not improve with ESA therapy. If no adequate improvement is seen over a 12-week escalation period, increasing the dose further is unlikely to improve response and may increase risks. Discontinuing ESA therapy at that time would be appropriate. I'll conclude this presentation with a list of references used to create this presentation. Thanks for tuning in.